Everybody okay? Everybody on board? Did we start?
Yes.
Okay, let's do it. So anyways, well, let's talk. I mean, this is pretty much an informal session with everybody. And I wanted to share a little bit my experience with everybody. I've always been fond of teaching. I always thought it was, as a physician, as a scientist, you have an obligation to teach the next generation. That's part of your job. It's not only taking care of patients, but also teaching, making sure that whatever you have here in your brain can pass on to the next generation, because that's what's amazing about medicine, is that we've learned from our, from our mentors. Mentors learned from their mentors. So as one of my pulmonologists who I was working with as a medical student said, he always quotes these the Civil War things, and he said, ours are not to ask reason why, ask to do and die. What he was trying to say is pretty much, you just have to do what you have to do, even in the most difficult situations. You have to work hard and reach what you need to get, which is basically the reason you guys are here. The reason I'm here is to get at the end the best patient care possible for your patient. So if we, I think we'll talk about the eye emergencies first initially, and then we'll talk about important things for the future of medicine and what I feel medicine is going. I mean, there's certainly medicine has changed over the past, 20, 30 years all over the world. So you need to kind of change along with that. But if you stay static, then I think you will people will pass you, and you'll stay behind. So let's talk about eye emergency. So when you're a medical student, when I was a medical student, we did go to the emergency room. We had rotations, the emergency department, and one of the most common things that we saw was epithelial defects. So I'm not sure how familiar you guys are with with epithelial defects, but generally speaking, it's a scratch. It's a scratch of the surface of the cornea, which makes it very, very painful. And the reason why, because the cornea has the most nerves in the entire human body. So it's a very sensitive part of the body. And you probably experienced that, getting a hair or a lash in your eye, which just, keeps you going for hours until you find that hair. So so that's one of the most common things. So the way to diagnose, of course, corneal epithelial defect, you have to use a fluorescein stain. You have to put a corneal stain, a fluorescein strip, and that be placed, whether an eye drop, fluorescein drop inside the eye, and then you shine an ultraviolet light, and then you will see the green defect in the cornea. I'm sorry, I don't have any. I'm not showing. This is not a lecture. We're just talking about these things. So having done, usually it's because of a scratch. If you see somebody in the emergency department, is because of motor vehicle accident, because something got in the eye, or because like a kid, hit his mom, or like a fingernail injury to the cornea. So those are the three most common things. And one of the most common things as well is post anesthesia surgery. So if somebody's having general anesthesia surgery, and whoever's going to be an anesthesiologist need to think about that, because usually they cover the lid with a plaster. And what happens, the eye during the general anesthesia stays open, and that plaster causes the epithelial defect, because for some reason it's not closed in the correct manner. So that plaster or that tape can injure the cornea. So, and then, you know, people come out of major surgeries and the only thing they complain about is their eye. Honestly, I mean, one of the biggest issues we have in my residency training program is that we get called at 2 a.m., at 12 p.m., and, you know, 11 p.m. for patients complaining. And so they send us a consult, patient having eye pain. So we have to leave her home, you know, and we're ophthalmologists. We're pretty lazy about getting called. They're like, oh, what is going on here? What, you know, we have to go in, and we know what happened. We know that the anesthesia screwed up. So so we go there, and okay, and my residency program was pretty adamant about making sure every consult, even if it was an eyelash in the eye, we have to do a full, complete eye assessment. Where they don't accept, oh, just putting a fluorescein, oh, this is an epithelial defect, and you write your treatment. No, we had to dilate the patient, we had to check pressure, we had to do everything. It was unacceptable. And actually, that's one of the reasons now I look back, is that the fact that they made us so thorough in making our physical examination, is that why, you know, I think I'm pretty good at what I'm doing. Okay, so it's because they made me do all the basic things. So you can take that and think about other things that you do. Let's say general eye examination, examination of the heart, examination of the limbs, of the maybe wrist. So you really need to kind of do a very thorough physical examination, and that's what we don't want to lose as physicians, is the physical examination. Because if you can diagnose people from your physical exam, then you'll be the best physician ever. So what I noticed over the past, 10 years almost in Kurdistan working here, is that there's a lack in basics of whatever, in my specialty, basics ophthalmology, you know, maybe look at in the anterior chamber, looking for cells of flare, looking for, just little things, looking at the gutara, looking at the endothelium of the cornea, doing corneal sensation, just general basic. I'm not talking, you know, scleral depression exam where you need to look at the periphery of the retina. No, I'm talking slit lamp. You look through the slit lamp and you look at the anterior part of the eye. And I see that, unfortunately, some residents don't have those skills. So you really need to kind of do those things. And I mean, I used to spend time with the patient, listening to the heart, mitral valve regurgitation, listen to the crepitus, crackles versus crepitus versus whatever, I mean, I still remember those things. And actually those basic medicine things helped me a lot in my career, because, as you know, ophthalmology has a lot of systemic association. I mean, our diseases that we see in the clinic has a lot of other systemic repercussions or associations, a better term. So we go back, epithelial defect is very important. You have to treat it immediately with antibiotics, avoid steroids, you give a lot of lubrications, and you patch the eye. It's very important to patch the eye. And what I mean by patching the eye is that you have to put a lot of gauze and tape it really hard, so the lid doesn't move as much, so the patient doesn't experience a lot of pain. Okay, so we talked about the epithelial defect. Let's go to the next major ophthalmology. Nobody's putting their videos on. I can't see you guys. Why you guys so... Oh, there you guys. I see you. I changed my screen. So please feel free to interrupt me. Okay, so let's talk about open globe. So you have to know that, well, I'm going to give you some pearls that you need to learn during your, I'm going to just learn. I told Amar Zaman about these pearls things. So most people don't know the difference between an emergency and urgency. People really don't know, oh, this is an emergency. No, it's really not an emergency. It's an urgent care, but not an emergent care. So I would say a corneal epithelial defect is an urgent matter, but it's not an emergent matter. So when we talk about open globe, that's emergency. So so what is an open globe? Open globe meaning there's a cut in the eye. It's like there's a wound. The eye is usually is an enclosed space. There's nothing comes in and out of the eye. Even the blood supply circulation is, you can say, a little bit different because there's an inner blood-brain barrier between the eye and outside the eye. So sometimes when we do injections inside the eye, this medicine doesn't go outside. Of course, there are some minuscule amount of medicine may go outside of the eye, but there's the blood-brain barrier that prevents that medicine from the inside of the eye to go outside. It's the same from the outside into the inside. So whenever this enclosed space is cut, let's say corneal laceration. Laceration is mean full thickness, right? And abrasion is a scratch. So laceration of the entire globe, meaning the inside of the eye is exposed to the outside. So that means bacteria can get in the eye. That's mean a lot of things can happen. Vitreous can go outside of the eye. The aqueous humor can go outside the eye. So pretty much like a puncture, like a tire and punctured, right? It loses its pressure. So when you look at the CT and when you look at the MRI, you see a squished eye. Next time you're in an emergency room, look at the eye, the globe. That's why we say when we look at the CT scan, we say this is intact. The globe is intact. The globe meaning the eye. The globe is not intact. So it means it's been penetrated. So there's a through injury, that's mean the bullet can go inside the eye and come outside the eye. And there's a penetrating injury, that's mean something, a projectile or anything can go from the front and maybe sits in the bottom of the globe inside the eye. So like a foreign body. But a through injury goes in and then out. So there are different types of open globe injury, but the most important thing about open globe injuries is the timing of the repair. When you know there's open globe, you have to repair the eye within 4 hours. That's the key word here. 4 hours is a crucial time to repair the eye. And why is that? Because we have a lot of research, and it says 4 hours is the cutoff period when you start having lots of complications like bacterial endophthalmitis. Endophthalmitis is basically an infection inside the eye. So we want to prevent infection inside the eye. So when you see a patient in the operation in the ER, they need to be repaired as soon as possible. And to be honest, I see a lot of people, sometimes they go for days unrepaired. And it's not because the doctors or the system, sometimes a lot of the time the patient, because they ask for 100% success rate and they don't realize that the doctor is trying to tell them, we're just trying to repair the eye. We're just trying to close it. If there's an internal injury or if there's any problem like cataract, traumatic cataract, or if there's retinal detachment, there's a vitreous hemorrhage, that means it needs to be repaired at a different time. But the initial issue, the initial thing is that you need to repair the globe. You need to close the wound. So I'm looking at here. As you we can't hear him. Is this new? Okay. So how is an open globe not an urgency? It's an emergency. It's not an urgency. So it's not an urgency, it's an emergency. Emergency, it means now. It means stats. You know stat, right? STAT, it's mean now. Urgency, okay, I can take care of things and then get back to it as soon as possible. No, you need to leave everything and just do do it now. So can I share some stories I have about?
Yes,
Okay.
yes.
So one time I was called in about 4 a.m. I was at I was in University of Kansas Medical Center. I was a resident there. Maybe I was I was a first year resident, which means I finished my internship and I was a first year ophthalmology resident. And we were 3 residents in that program. So every year there are three stages or 3 levels. I was a first year postgraduate year 2, and there were 3 more on top of me and 3 more on top. So one of my colleagues dropped out. He couldn't handle the pressure. Okay, so it was me and my co-resident, Erin Stahl. She's an ophthalmologist in Kansas City. So, man, I was 1 week on, 1 week off, 1 week on, 1 week off. And I had to study, and I had to study for my OCAP exams. And I got called at 3:30, maybe 4 a.m. I mean, 4 a.m., that's in your REM, rapid eye movement. That's you're like dreaming and you're right deep, right? Called in, says, doctor, you better be here quickly as soon as possible. The helicopter is coming down now. It's like, what's going on? Helicopters, things going on. Okay, so thank God I live close to the hospital. So I get in my scrubs and then get going. I was probably there in about 10 minutes. I get there, go in the room. It's like, that room. So that's what the emergency medicine doc was saying. It's like, what is going on? There's something weird here. Anyways, so I open the door and I get this whiff of alcohol. Basically, I mean, you see that a lot in the US. A lot of people get drunk and they go to the emergency room because of a lot of things. So, and then I get in and I see a naked woman. So I take a deep breath. I go in there. I say, hello, ma'am. And then I take the sheet and I try to cover her. And then she takes a sheet off. I put it back in. She takes the sheet off. Yeah, she was beautiful, looking lady. And so I keep covering and she keep taking the sheet. I was like, forget it. I need to do this exam as quickly as possible. So obviously I look in and then, eye is so traumatized, so edematous. There's blood coming out. Anyway, so the story goes is that she was in a strip club and she was trying to get on the stage, and she was fighting with her other girl, and then she was telling her some bad words we're not going to say here. So that the lady, she was getting on the stage, she was going after that stripper, and then with this huge stiletto, she goes and nails her right in the eye. So she had a stiletto ruptured globe. So I was dealing with a stiletto ruptured globe. Yeah, of course, the rupture was like 12 millimeter going from the interior part of the eye all the way to the posterior part. The thing about ruptured globe, even if there is no hope for that eye, you have to repair it. That's the rule. And because sometimes you may salvage some vision from those eyes. So anyways, we sat down. By the time I got the paperwork, I mean, the paperwork in the US and in hospitals is just ridiculous. I mean, I sit down there. Now it's different because you do a lot of things on the computer, but it's a lot of work, even on the computer. So I used to fill out all these forms. I swear, they were like this much of paperwork I had to do. By the time we got in the OR, it was 5:30. And then, it took us maybe 3-4 hours. Of course, I was just watching. I was just a first year resident. I didn't get my hands wet. And then the third year resident did pretty much everything. And, I'm like dozing off, and I have work at 8. I have to be in the clinic at 8. So 5:30, before 8, I leave, I go to the clinic and I start my, day work. So I didn't get much sleep that day. Anyway, so open globe is emergency, not urgency. Repair it as soon as possible. So let's talk about herpetic. A corneal ulcer is pretty much if you have an epithelial defect, okay, and if you don't take care of it, if you don't treat it with antibiotics, then it's going to go to a corneal ulcer. Corneal ulcers mean there is a scratch in the corneal, epithelial is broken down, and the bacteria has invaded the stroma, has invaded the cornea. There are like 5 layers in the cornea, so the infection goes inside the cornea, and that's also an urgent matters. There's some also emergent corneal ulcers, and there's urgent corneal ulcers, and you have to treat it aggressively with antibiotics every hour, antibiotics, and follow up daily until that corneal ulcer heals. Of course, there are different types of corneal ulcers. You have bacterial corneal ulcer, you have viral corneal ulcer, and you have fungal corneal ulcers as well, right? So you have to take care of that. And also you have to do the fluorescein, and look at the epithelium and look at that. So I'm going to look at who's here. Wow, how many people we have? 81. Great. So herpetic eye disease is pretty much a virus. The virus, when we pretty much all have HSV. We all have herpes, and probably I would say 90% of people have herpes. We have it in, when we get tired, our immune system goes down, we get angry, we're under a lot of stress. I'm sure you guys are under a lot of stress, and you get that a lot because you get it. So the same thing can happen in the cornea. So one of the most important signs to look for when you have herpetic, I think, is to look for Hutchinson's sign, right? When the herpes affecting the tip of the nose, that means most likely the cornea has been affected. So you need to look at the tip of the nose, make sure you look at the corneal sensation. Most of these patients who have herpetic eye disease and herpetic ulcer, and how you differentiate it from bacterial ulcer is by checking the sensation of the cornea, because the herpetic corneal ulcers can cause decrease in the sensation of the cornea. Of course, you have to treat it with acyclovir, as you have heard, and acyclovir is a treatment management for herpetic eye disease. One thing, as a medical student, we talk about retinoblastoma now. Retinoblastoma is a very, very dangerous disease, and unfortunately, I see a lot of very late diagnosed retinoblastoma. So when they come to me, they're coming at a stage where I can't help them. Okay, so and it's a simple thing you can do, and you can, you have an ophthalmoscope, right? And then you can just look at the ophthalmoscope, dial in so you can see the red reflex of the baby. And you do both eyes, you look at the red reflex, you get back like 1 meter or 2 meters, and you look with the red reflex and look at the red reflex in both eyes. If you see a white reflex, then you have to worry about retinal detachment, you worry about retinoblastoma, because these things you cannot miss. You cannot miss something that can kill a patient. And if you take the American Board in whatever, American Board of Ophthalmology, American Board of Internal Medicine or surgery, those questions are, you're going to see it. Anything that can kill a patient, you have to know. So retinoblastoma is a big deal, right? There are some congenital heart diseases, right, that you need to know, probably just from listening to the patient or from the echo, or just there's so many things that can kill the patient. So also these mitochondrial diseases, those biochemistry things that can kill patients, those things you need to memorize. because board examiners focus on this, on these things. They just need to know your. See, the things about American medicine, you need to realize. American medicine, and the reason why it's such a great system, is because they focus on making the physician as a safe physician. So I always say, when you graduate from there, when you do your job correctly, when you finish your residency, they are pretty adamant about making sure when you get out, you don't hurt the patient. That's number one rule. You know, in medicine, what is the number one rule? Do no harm, right? Don't hurt the patient. If you do surgery and you hurt the patient, like, it's not, I mean, don't do anything, you know, like, don't give him something that hurts him. Don't, it's better maybe not to do anything than to do something, right? So I see a lot of patients that I don't surgery. I refuse to do surgery, or I think that I may cause harm, that that I know the surgery may be harmful to them, then, I just say, I'm sorry, I can't do it, or I won't do it. So what were we talking about? I kind of, Qamar Zaman, you need to help me. I don't know what I was talking about.
We're
I
talking.
digress. I'm sorry. I digress, but I think it's important to digress and talk about, because it's boring if I just talk about.
Yeah, no. This is very interesting. This is really
So I'm
interesting.
giving you this. Do no harm. Keep that in mind, because if you see a patient and you think about do no harm, then you will do fine. So the way I tell people why people want to go, and with all due respect to you guys, and you guys are different generation, you'll do amazing things in the future. I know that. But if you go to the States, and if you go to, okay, you have any medical problem, and you just see a doctor, okay, there's a doctor here, I'm just going to go in and get checked. There's a 90% of the, I think 90% of the time you get into that clinic or that place, and then you will get the correct treatment in an ethical manner, in a safe manner, and you'll get the right medication, and you'll be fine. Of course, there's maybe 10%, 5% of people who don't know what they're doing, even in the US. Seriously, and they're even in the US, there are people who don't know what they're doing. So unfortunately, in third world countries, it's it's kind of vice versa. And I'm not talking about here, I'm talking in general. Okay, so we want to make sure that when patients come to us, they feel safe. And one of the things people tell me is that they trust me. Right? They trust me. They come to me. Oh, we've heard about you. This is what, your name and this. Why? Because they know I will make the right decision for them. So when a patient comes and I examine their patient and I say, oh, I'm sorry, you don't have cataract. Well, doctor, I was told I have cataract and I need cataract surgery and I need to do it as soon as possible. Well, no, you don't. You just need glasses. Or you don't need it. It's not there yet. So what I'm trying to say, they trust me, and that's mean I'm not going to do something to hurt them. Okay.
Can I
So
please add on what you just said? My grandfather, last year, not 2 years ago, went to 3 different doctors for his eyes, and he did not feel comfortable with any of them. All of them gave him the wrong medication. One of them was about to operate a certain surgery that would have probably gotten him blind, but then he came here to Dr. Hasan, and he now he comes and checks his eyes regularly every 6 months. And mind you, he's a man in his 70s. Old men, they never go to the doctor unless it's urgent. And now he comes here to the American Eye and Retina
yes,
Center and checks his eyes every 6 months because he was so comfortable with the doctor, and the treatment and the surgery went so well. But he's having regular checkups to something he's like, he thinks that is very unnecessary. But he's doing the regular checkups just because he trusts Dr. Hassan and the center as well, the people working there as well. This is just my story.
So thank you, Qamar Zama. I appreciate that's really nice of you. So the thing is about this story or whatever stories you may face. So if you're in your mind, if your target, if your what you want to do is make that patient or do the right thing for that patient, okay, you will never go wrong. This patient, if you know, there's always this, just remember this, so there's another pearl. There's always this something in the back of the mind, your mind. Yeah, it's a simple cataract surgery. Yeah, I'll just take it out. Yeah, his 2+ will be fine, and then he'll be happy. Those are the patients that get complications. Those are the patients that, oh, well, you know, I mean, this, I mean, let me do a facelift for you and you look great. Whatever. I mean, let's talk about cosmetic surgery, or let me do this filler right here and it looks just fine. And then the filler can cause a ciliary retinal artery occlusion. Did you know that? If you put a filler here, why? Because that's where the facial arteries anastomosis here. But if the patient really needed it, okay, and you said, you know what, you know, weighing the benefit risk, if patient comes, says, listen, doc, you know, I'm just having, I can't get on TV, I can't go on Zoom with my friends, I can't take a picture, it looks really bad. There's, you know, that patient is suffering, that patient is having some issues, right? And your goal is to help that patient feel better about themselves. I'm talking cosmetic surgery. Cosmetic surgery is important, okay? Nowadays, you see it everywhere, right? So your intention is to make that patient do well, then you will do this procedure and that patient won't have complications. The moment you kind of compromise your ethics, the moment you compromise, you know, you kind of feel like this thing in the back of my, yeah, do it, do it, do it. And then it's like, no, you have to kind of stop yourself and just talk to yourself and say, no, I think this is not right. Let me just leave it. I swear, instead of one cataract surgery, you'll get 10. And instead of one filler, you will get 10 fillers. If you just tell the patient, oh, you don't need it. So where are we now? So let's go back. So, oh, did you know about if you snooze, you lose as a medical student? Right? Never snooze, guys. Never snooze. If you snooze, you lose. I never snooze. That's why I was able to do what I did. So if you snooze, you lose. Except I snooze all the freaking time in the morning. Every day. I mean, my wife just really, you know, goes crazy from this snoozing thing. So, okay, we talked about baby reflex, retinoblastoma. Retinoblastoma, check it. White reflex, that's leukocoria. You need to know leukocoria. Or if the eye is deviating to one side or the other, they need to get checked. They need to have their retina examined. You have no idea how many times I've seen babies who have like esotropia or exotropia, who were just checked and given glasses. No, they need to have the retina checked to look at for any toxocara scars. Toxocara, it's a kind of, it's a cannon worm that can go inside the eye. Toxoplasma, retinal detachment, macular dragging, retinoblastoma. I mean, so many pathology can happen in the back of the eye. So you have to make sure. Why people not showing? Just there's few people here. Oh, I see. Why people are?
No, there's a lot of people here, but there's only, I think, 13 people who have their camera
Videos.
on.
What?
Yes.
Oh, the people are so shy
They're,
nowadays
they're shy.
with the social media. You guys are shy. Come on, let me see your face.
Especially this generation.
Wow, you guys, this social media generation.
مع
Well, I'm
العلم.
there. I'm with you almost. So let's talk about what else. What time is it? What time do we have to finish?
Whenever you feel like finishing.
How's it going? Seriously, do you like what I'm saying? I mean, is it
Yes.
okay? Do you feel this is
I like
good?
it.
Seriously, just give me a heads up, like a nod. Is it okay?
It's going great,
Yes.
doctor. Thank you.
It's great.
All right. So let's talk about what to expect as a future doc. So do you have any questions about these eye emergencies, please? So let's have somebody say something. Any questions? Can you tell us about one of the challenges medicine-wise that you faced during the recent pandemic? So there's so many challenges. I mean, I had number of patients go blind because they couldn't follow up. And they just bluntly say, sorry, I couldn't make it. I couldn't follow up. I couldn't come. I do some surgeries, major surgeries. I put silicone in the eye, and the silicone has to be monitored, made sure that doesn't causing high in the intraocular pressure. And people lost their eyesight because the optic nerve died because the pressure went up. And I wasn't there to help them. I wasn't there to take care of that problem or remove that silicone oil. There were a lot of people with macular degeneration who did not come for their injections. We inject inside the eye, anti-VEGF. By the way, you hear a lot of maybe bad talk about injection inside the eye. It's the best thing ever happened in ophthalmology. Best thing, okay? Since 2003, 4, something like that. That's when an injection started. It's the best thing ever happened. So it's not the injections the problem we have with. It's the way to use the injections. Oh, so people get infection? Yes, they do get infection, just like anything. People can die from penicillin, right? From having an allergic reaction to penicillin. So the same thing, you can have an infection from the injection. Okay, so just remember, injections or anti-VEGF injections are one of the safest things and best things ever happen in ophthalmology. It saved millions, hundreds of millions, not even billions of people from losing their sight because of this amazing injections. Okay, and challenges. Well, if you follow me, you see I'm wearing 3 masks until now. I wear 3 masks, and that's the only way I have been able to protect myself from corona, from COVID-19. I haven't gotten COVID-19. I did take the Chinese vaccine February 11 when I was visiting my dad because I was taking care of him because he had COVID-19 in Amman, Jordan. So I went and visited him. So that time I, put in the Manassa in Jordan, I put my name, and sure enough, I was one of the first people to get it because I was a doctor, I guess. So that was really tough. And the thing is, see, you are going to get either the vaccine or COVID-19. And corona, you're going to be hit by corona at any time. So get corona while you have the vaccine on board. It's better for you. It's more protection, right? So, and you have to, you are instrumental in educating your families, your loved ones, and making sure that people get the vaccine. Because unfortunately, people are not getting the vaccine. So, what other challenges?
One of the biggest misconceptions that people have regarding corona, I'm so sorry for interrupting,
no, please.
Is that you don't get corona if you get the vaccine. You will get corona if you get the vaccine, even if you get both doses, but you won't have as intense manifestations of the disease as you would have without the vaccine.
Yeah, so
you still get it.
lessens the hospitalization. So even though AstraZeneca, I was reading about that the other day.
It causes blood clots. That's what they said.
Well, but corona causes blood clots.
The thing is, my dad is in the public health department, and he was one of the first people to ever get the vaccine.
Yeah.
And back then, he got the Chinese vaccine, and everyone was calling him so brave. Oh my God, you're so brave! You got the vaccine. He's like, it's a vaccine. It's a vaccine. Where is the bravery in the whole thing?
So the thing is about this this Chinese versus AstraZeneca thing. Honestly, I mean, I have no clue what the Chinese vaccine efficacy, research, nothing, no information whatsoever. Let's be honest. And I took the Chinese vaccine, right? Sinopharm.
My
The issue people don't realize is that AstraZeneca, the reason there's all this hype up about AstraZeneca is we have information, we have data, we have, complications, risks, and all this. It's good, that's important, but the risk is very minuscule. 7 people died in 2.5 million, 2.5 million. I mean, but nobody's talking about the Chinese vaccine. I took the Chinese vaccine, and I didn't have information about the Chinese vaccine. Just people. So let's get into that. Okay, that's a good thing to talk about. Evidence-based medicine.
Yes.
This is not a say here. In Arabic, qishba. This is science. We're doctors. So don't tell me somebody said that. Don't tell me no, give me evidence. Show me the evidence. Like, I don't know, have you seen that movie of Tom Cruise? Show me the money. Have you guys seen it? Well, say, show me the evidence, right? We're doctors. Evidence-based medicine. Okay, AstraZeneca has an evidence-based medicine behind it. Sinopharm, I'm not sure, to be honest. Right? Anyways, so we go back to the issue of what are we talking about? I forgot.
We're talking about yeah.
What?
I don't know either.
If anyone has any questions, that's why.
Okay, any questions? I digressed again.
Oh, someone just said.
That's why people follow me, because I talk about like maybe just random things.
One of the things that like make Dr. Hasan really singular in the medical field, and he can express all this accumulated information and years of experience in a language that's very easy to digest. بحيث sometimes, like when I'm in university and I have nothing to do, I would just watch one of his videos, learn something, but also not feel, it wouldn't feel very
lost.
Educational.
You wouldn't feel lost.
It wouldn't feel too educational. There's some fun to it.
Yeah.
You know what I mean? Yeah. And this is something we can all use.
So that's a good point. So when I talk to my patients, I go down to their level and I bring something. I'm sorry, but I say, the retina looks like a freeze, like, lawn. Yeah, and there's water in the lawn and there's fluid in the lawn and we need to dry this fluid. I mean, you really need to come down to their level, explain to them. And then I see a lot of physicians talk over people's head. It's just like, and they get out. It's like, we didn't get it. I mean, people say I do that, but honestly, I try my best not, to talk slowly, explain things. And even when I do, anything related to ophthalmology, I can speak Kurdish very well. It's something to do with the eye. I know pretty much well. When it gets out of the eye, I kind of lose track. I can get my way, so now when I speak Kurdish now, but the thing, what I'm trying to say, even when I have a translator, okay, let's say you're Kurdish speaking doctor and you have an Arabic patient coming to you, let the person translating, give them time to say what you need and stop. And then they say something and then you say, and then you stop. So you kind of give time. So communications, one of the important things as being a physician is communication. That's extremely important. Oh, and let's say one of the biggest thing, there's a huge lecture in the American Board of Ophthalmology about communication between healthcare professionals. I'm talking about physicians, pharmacists, and you name it. Do you know what's the number one reason for medical mistakes? Number one reason.
Miscommunication.
Perfect. Yes, miscommunication. It's not that the doctor is not smart. It's not that the doctor doesn't know what he's doing. It's not, well, he told somebody, you know, give him penicillin, and the guy gives them ceftriaxone or whatever. And he heard it on the phone, because there are a lot of medicine that sounds the same. I have a, by the way, I have finished a pharmacy degree before I went to medical school, and a lot of people are like, what the, how did he's a pharmacist? I was like, yes, I'm a pharmacist and a doctor. Because in 2000 I went to pharmacy school, because I didn't think I was going to get into medical school. And when I graduated, I didn't think I was going to get into pharmacy school, in medical school. So I went to pharmacy school in the US as a pre-med, because in the US you have to go to a pre-med before you go into medical school. So instead of choosing biochemistry, chemistry, or whatever before going to medical school, I chose pharmacy. It was an extra year because it was a 5-year program. So I said, okay, I'm going to spend this extra year and then apply to medical school, so I have better chances of getting into medical school. And in case I don't get into medical school, well, at least I have a profession to fall back on. And sure enough, thanks God, I worked hard, and I got, you know, I was in the honor program at the pharmacy school, University of Texas, and then I applied to medical school and I got in. So one of the things they taught us in pharmacy school is the names, because we talk to doctors over the phone, and even the way things are written in English language, it sounds the same. So there's a huge, big deal thing about communication in medicine. And there's a lot, big thing is that is people miscommunicate and people die, and people have harm. They get harmed from the treatment. So let's ask, there's a, doctor, does LASIK surgery have a long-term side effect? So first of all, I'm gonna see, the thing is, see, honesty is amazing in medicine. It's the essence of medicine. Okay, honesty. You think I'll be shy and I can wear contact lens and I can hide my glasses from my patients, right? Most people are like, I'm a doctor and I need to do laser surgery, and people won't do the laser surgery because I'm wearing glasses. Well, I'm wearing glasses because I can't get laser surgery. I can't get LASIK because my cornea thickness is thin. Okay. Number two is my stigmatism is there's a regular stigmatism and there's irregular stigmatism. So if I do laser surgery, then I cause more harm. I cause harm to myself. So when I was a 23-year-old, when I was a medical student, I was in Galveston, Texas, where my medical school was. I went to Houston because there was a famous refractive surgeon there. Right? He did the test and just found out. He told me, Doc, you can, you know, I was not a doc, I was a medical student, but he told me, Doc, you can have laser surgery because of these things. And now patients ask me all the time, well, Doc, and you should see my Facebook and Instagram. They laugh about me and they say these things and you're lying to people and all that stuff. No, people ask me and I tell them exactly the truth. And those people that make fun of me and ask me and say why you're wearing glasses, and I tell them the truth, those are the patients that come and do surgery. Crazy, huh? Yeah, because, you know, it's just simple. It's simple. I'm just telling them the truth. So laser surgery side effects, you know, people, you know, about 5% chance people get dryness. They get long standing dryness, dry eye syndrome. So they have to use, you know, artificial tears for the rest of their lives. They can get halos, where if you're looking at a car coming at you from a distance, you see around those lights, you see halos. Okay, and they get some kind, because that happens when the treatment zone is a small treatment zone, and the patient pupil is large. Okay, so we have to assess those things also before surgery. But it's one of the safest procedure in the world. That's why everybody knows about it. Do you know a surgery called TURB? Who knows surgery called TURB? TURB? TURB. transurethral, right? Radio frequency.
It's for the prostate.
Exactly. TURB. It's a TURB. But not many people know this procedure, right? Because it's not famous. We are more famous as an ophthalmologist. We do surgeries that make us famous. It's LASIK, laser surgery, because it touches people's life. It's a highly successful surgery and people do great. The thing about laser surgery is that people who do well don't say much. They say to one person. This is real statistics, science. They say to one person, "Oh, I did amazing. I had laser surgery." But a bad outcome of laser surgery, they would tell 10 people. This is pretty well known. Yeah, so you're most likely to hear that I didn't do well from laser surgery than I did well. But most people are doing well. So let's go talk about expect future doctors and criteria for success. So let's go talk about the future of medicine. Enough of medicine. So I think it's different in the developed world versus third world countries. I think in the US and Britain, Europe, I think there's more, it's becoming more commercial. And what I mean by that, commercialization of medicine. And what I mean by that, when I was a medical student, I went and I had a rotation with one of those family medicine docs between Galveston and Houston. And it was one of those cowboys kind of person, wears his jeans in the clinic and everybody's a friend. He knows everybody. He knows all their families. Yeah, everybody knows him. He's a family doc, one of those traditional family docs. And those practices are becoming less and less in the US. Okay. And what I mean is that large healthcare companies and large healthcare organizations are buying these little bitty practices, and they're buying them and they're including it into their big healthcare organization, and they're hiring physician as employee, right? So instead of you hiring your own staff, renting a place, bringing your own accountant, billing for yourself, you're just becoming as an employee. You come at 8, you do your job, you file your things, and you complete your paperwork, and then at 5 you leave. So that's how, and the reason why, because a lot of doctors, because honestly, medicine is becoming less lucrative than in the past. And do you know what that means? Less lucrative than in the past? It's becoming less money. Doctors are making less money than in the past. Okay. So if you're talking about an orthopedic surgeon in the US in the 80s and 90s, like my uncle, he's one of the most famous orthopedic surgeons in Houston, Texas. Okay. That time people made millions, and you're talking millions in the 80s and 90s. That's a lot of chunk of money at that time. Nowadays, an orthopedic surgeon maybe start at around $400, $500, maybe $600,000 per year, depending on their subspecialty. So because the reimbursement for procedures, reimbursement for patient, reimbursement for the clinic visits, all going down. So what happened, and I think I'm one of the first generation when I went to medical school. Most of medical students in my my class were looking more at lifestyle than money and monetary income, right? So they wanted to leave early, spend time with their families. They didn't want to have lots of calls, and the same thing happened. A revolution happened even when I was starting residency. It's 2005, 6. I entered residency as an intern in 2006, is that the ACGME, or the American Continuous Medical Education, ACGME, it's pretty much the organization that oversees all the residency programs in the country, in the US. People getting a lot of complaint about residents, spending over 80 hours, 100 hours working with, no time off. They're always on call. And so there was a pushback from residents, from doctors, says we can't work this much of time. We're not getting paid. We get paid $2,000-3,000. We don't have the means to live, and we're already in debt. We have a lot of loans already from medical school. So a lot of people went into anesthesiology, went into radiology, because it was high, good paying salaries, but at the same time, lifestyle was nicer than being an orthopedic surgeon, spending many hours working on call and taking call. So that's kind of has changed. So doctors in the US don't want to kind of work 24 hours like they used to. Things have changed. There's a pushback against doctors, and things that were okay at that time, now it's not okay. There's a lot of other healthcare workers who are getting into the business, like PA, physician assistants, getting in the business, PharmD, doctors of pharmacy, getting into the business. So there's a lot of competition. So we're talking about commercialization. That's what I'm saying. There's a big companies going into it, and those private practices that are the mainstay of medicine, that are, I would say, the pillars of medicine, is changing. That is not as much as seen in the third world countries. In the third world countries, let's say countries like Jordan, like Iraq, still traditional medicine. You go open up your shop and you see patients. But I see maybe whatever happens in the developed countries, I think it will happen in the third world countries, but it takes longer, takes more time to come to us. So I think that's a big part that is happening, I think, in medicine. Criteria set for success of our generation. My advice to you is just do the best you can do. Be the best physician you can be, and you'll be successful whatever you do. Okay, if you are doing the right thing, and I'm talking even when you do the injections correctly, intramuscular injection, people take lightly, right? I mean, even when you do the vaccine, right? I've been taught, I'm talking now back to the basics. When you go, you have to feel the deltoid, pinch the deltoid, get the injection, not sub-Q, it's intramuscular, right? There's a difference. The vaccine has to go intramuscular, not sub-Q, not in the fat area. So if you have a person who is overweight, you really need to feel the deltoid and get that vaccine, because I see these things, and I had good training as a medical student. And the same thing with wearing the gloves in the operation room. If you notice that I'm very adamant about getting those things, like people having the nose out in the operation room, that's, as far as I'm concerned, is a definitely no. Why would your nose be in the operation room? Your nose should not be in the operation room. Your hands should be in the operating field, right? The nose is a dirty thing and shouldn't be, honestly. I mean, these are basic things, and don't compromise your basic things. When I came to Kurdistan, one of the things I said to myself, if one day I feel that I'm compromising my ethics or compromising whatever I learned, then I'm not going to stay. Because because everybody is learning how to do things the way they're doing, right? And then it's difficult to change a system. You can't change a system, but you have to keep your own system, and you protect your system from being penetrating by somebody doing the things the wrong way. And I'm talking from your assistant, surgery assistant. She's doing something her way, and that's how she knows. Okay, so you have to continue saying, that's not the right way, you have to do it my way, the right way, right? Same thing. And you have to be also a leader. You have to show them. If you see something in the operation room on the, on the floor, go and pick it up, not because you're a surgeon and you're above people and you think you're God and everything. No, if you pick it up, then they'll go and pick it up before you do. You have to be a role model for your for people around you. If there's a dirt, just go ahead and clean it. Do things in front of them, and they will follow you. Just do it the right way. So that's the thing about being successful in medicine. Okay, and what else? I think we can go to. Do you have any questions about the subject? And we can talk. Do you think about mid-level? Well, it's TERP. TERP, yes, TERP. Thank you, Rabin. Appreciate it. My question is how do you manage to stay motivated, or any advice on medical? Stay motivated. It's you have bad days and good days. You have to think of something bigger than yourself to always be motivated. I mean, you have to kind of. I've always, think of, I have to save everybody and I have to do something great, and I want to do some big things, and I want to, great things. And I mean, that's how you stay motivated. And you have to have some kind of things to keep you motivated. What else? Will be replaced by AL and B Janners in 20. Because, as you know, it's difficult during our age. So, doctor, do you advise us to be explicit with patients? Okay, so that's next to the informed consent. Explicit in what? I mean, be a little bit more specific. Explicit about the informed consent. So I think one of the reasons I've been successful in what I'm doing is that as I came here and I learned about the system, there's, every place has a system, but I kept my own system, which is the, I think, hallmark of American medicine, is informed consent. It is very important that you do a very thorough informed consent. What do you think about mid-level creep in the US healthcare system? Some states allow PAs and NPs without supervision. What do you think about the system here? I think it's too early for the system to be here. Not because I don't trust PAs and nurses to do things. No, it's not that. But in the US, even though there's a very highly regulated system with a very very strong criteria for things, it still has problems. Right? There are people, PAs, doing things they shouldn't be doing, as far as, so I think that's a big subject, and I don't want to go into it. I think it depends. There are a lot of places in the US where they don't have physicians that, like, in the outs, not cities. People don't live. Not everybody live in a city in Manhattan and New York and Houston. People live out in the country sometimes, and they don't have access to a physician. So in these instances, PAs are instrumental, nurses are instrumental to providing care for those people. So it just depends. I mean, there's so many things you can go into it. What do think about the system here, you know, I mean, as you guys know, the system has gone into a big change since my dad is a physician. I don't know if you guys know, he's a pediatrician, and he was part of the system. And my understanding, what I hear from my dad and I hear from my uncles and people that I hear, it was a great system. And of course, Iraq going through wars, through turmoil, through a lot of insecurities, you know, caused the system to degrade. That's natural. So it takes time for things to get back, right? A lot of physicians, a lot of well-known physicians left the system, whether, you know, in Iraq and Kurdistan, everywhere, you know. So it's obvious it takes time for that system to build back and to reach where it's supposed to be. So I think it takes time. And how did you decide on becoming an ophthalmologist, or why? Do you know that, before every every residency program, I interviewed at 9 residency programs. When I got out of medical school, you apply to residency a year before you finish, and you apply to becoming an ophthalmologist. You apply to ophthalmology programs, and that was one of the things they ask you. I think that's, I mean, I love the, I love being with patients. I love to interact with patients. I love being with people, and that's very important. That's why I didn't choose radiology. I mean, I think looking inside the eye for the first time, and being in the operation room and seeing the 3D aspects of ophthalmology, that was just shocking. That was just mesmerizing. That was just crazy. When you look inside the eye and you see the structure, when you see the iris for the first time, it's insane. It's like, I can't believe it's true. So, I mean, this shocking thing about ophthalmology, it's something that you see. I'm a visual person. I like to see things. There are people who just mentally think about things, and these people maybe become psychiatrists. I'm a more visual person, and I like to see things. The technology involved in ophthalmology, that always was a big plus for me, because I like, gadgets. I like things, and those things that I liked, and I didn't like other things. Interestingly, I'm going to tell you something which is really weird. Can you believe I was the president of the Orthopedic Surgery Society? Can you believe it? Where ophthalmology and orthopedic surgery, how does that work? Interestingly enough, most medical students who are interested in orthopedic also interested in ophthalmology. Explain that to me. Seriously, I mean, yeah, I mean, these are things I read and I seen, and there's statistics and samples. We before going to ophthalmology, we always look at these things, and there were websites you can go and see and look at these things. How does that work? Why would I'm interested in orthopedic? I love orthopedic surgery, by the way, and I published in one of the major journals in arthroscopy. And can you believe I wanted to get into orthopedics? And I was the president of this Orthopedic Surgery Society. I don't know how that happened. Anyways, so when I was doing my research, because, and when you want to get into orthopedics or ophthalmology, you need to get published. While in medical school, you need to get published in orthopedics. So when you go to residency interviews, people, oh, you published, oh, you helped us. So I used to go to the anatomy lab and all red, if you go to University of Texas, Galveston website, you see Old Red. It's a huge building. It's one of the oldest building in Texas or something like that. Oldest medical school, one of the oldest, I think Harvard and then UTMB. So I used to go walk to the lab, the orthopedic lab, the research lab was across the campus from this building. So I used to walk, and I used to go to the anatomy place, and I used to get cadavers, right? I used to get cadavers. So I used to get, because I was doing my research on the knee, I used to get all these legs, you know, probably 20 legs, and I stack them one on top of the other, and I put them in a trolley. I cover it, and I walk through the hospital, through the corridors. I walk across the campus all the way to the research lab, and I'm carrying all these cadavers, legs, you know, their legs are just stacked up legs right on top of the other. And then we put them, we anchor them, and then we do our research based on a 45 angle, 30 angle. I was working on the ACL, some kind of an ACL program. Another thing I did while I was a medical student, I did research at Baylor College of Medicine with my friend who married my cousin. His name is Tariq Fahal. He's an orthopedic surgeon now in Houston, Texas. And he was a fellow. He was an orthopedic surgery fellow. And I was like, you know, I want to get into orthopedics, and you need to help me. I need to get involved in some orthopedic surgery. He's like, yeah, okay. So he was trying to do his research, fellowship research paper. So I got in, I got involved. So one of the things, I had to go to this lab at Baylor College of Medicine, and I had to go to this lab where they have all these cadaver shoulders. Okay, so I open up this freezer, and there's all these, you know, legs and shoulders. I mean, it's just like those horror movies you see. And I get them out, and I thaw them, then I leave them for a few days, and next day I go, and I have to find the glenoid labrum. How do you get to the glenoid? You have to dissect all the muscles, and that was one of the toughest things. So I'm sitting here by myself in this lab somewhere out of nowhere. You know, nobody knows I'm there at 5 o'clock in the morning, 6 o'clock in the morning, and I'm dissecting these muscles, and I'm cutting with a saw, with a thing. And because the fellow, he wants only the glenoid labrum, where the socket sits, you know, with the shoulder. By the way, I just dislocated my shoulder a few times, and now I think I have a problem in the same thing I used to do. So he just wanted it. He wanted this little bitty thing. And I had this huge shoulder and all kind, and then I had to dissect everything. Oh, it was a nightmare. So I've seen a lot of dead bodies. By the way, one time I was in the anatomy lab with my friend. There, we were 200 students in medical school, and they gave us 50 cadavers. So every 4 students, we had a cadaver, like a tank, and we used to dissect those bodies. So we wanted to get hundreds in the anatomy lab. So I used to go with my friends to the anatomy lab early Saturday morning, like around 6 o'clock in the morning, to get, you know, head start, so nobody's there. And then we get into this old red. I wish I showed you this. Go to University of Texas Medical School at Galveston, okay? And go to the website, you'll see old red. And the end of that building, at the top level, the anatomy lab. So it was like a haunted house or something, I swear. I mean, you get into that building, you know, there are like so many bodies went into that building. So I go with my friend up to the top of the level, and me and my friend alone in this lab, in the anatomy lab. His name is Marco. He's a cardiologist in Houston, Texas now. And I swear we were working, and because, you know, anatomy is different from one body to another. And then the anatomy test is on different bodies. They tag this vagus nerve here, right? Vagal nerve here. They tag gastrocnemius muscle here. They on different bodies. So you have to know the anatomy on different bodies. not just one body, because it's different. So while we're working, I swear we saw somebody walk there. And it was just me and him alone. And that with 50 bodies, with all these, you know, what do you call this? Mummified, or what do you call it? I forgot this. They put them in this fluid. Come on, help me out. I totally
I think
forgot.
it's
Formalin.
fluoride.
Yeah,
Formalin.
formaldehyde and all these
Formaldehyde.
babies and, you know, defects, and, you know, that's anatomy lab. And there's 50 bodies, and I swear somebody went inside the women's changing room, and then the things start going right and left. I was like, listen, just put our head down and just work, and we just, as if we didn't see anything. So I've been around a lot of dead bodies in my lifetime. I've seen a lot of things. Oh my God, I digressed a lot. So informed consent. So one of the key things about medicine, whether you're doing an injection, whether you're doing surgery, or whatever you're doing, you need to have what we call RBA. You need to discuss three things: R, B, and A: risk, benefit, and alternative of the treatment. Okay, so you really need to talk about the risks of the surgery. So when I talk about ophthalmology, I talk about the risk of blindness. I tell all my patients, okay, a risk of blindness, they may lose an eye. Not because I did something wrong, because something happened suddenly, was not under your control. Okay, like a suprachoroidal hemorrhage. Patient blood pressure inside the operation room went up to 200, and the patient, you know, bled. Suprachoroidal hemorrhage is pretty much, you know, you can repair suprachoroidal hemorrhage. I'm not saying you can't repair it. I repair suprachoroidal hemorrhages, but patients can go blind from that. So other things can happen: infection, post-operative infection like endophthalmitis. Many things can occur that can lead to loss of life. You need to talk about it. If you're an anesthesiologist, you need to tell the patient about it. So somebody asked to be explicit. Yeah, talk about everything. I think spending, what I wrote here, so informed consent has two things. The way I think about informed consent is that, first of all, you're protecting the patient, because you're the patient's biggest advocate is you, and you need to understand what's an advocate. That's mean we work for the patient. We protect our patients. We are our patients' saviors. We're the patient's protectors. We're the patient's bodyguards. They're our families. We have to take care of them. So by doing the informed consent, you need to protect them. Okay. So for example, patient went around and she had an epiretinal membrane. Okay, epiretinal membrane. If you look at my clothes right now, so this is the retina sitting at the back of the eye. The epiretinal membrane sitting on the retina and puckering the retina. Puckering, this is what it's doing, right? Loci degree. Loci degree, and it's causing the retina to pucker. So she's a monocular lady. She has one eye. She's probably in her 75-year-old. She's living out in the village somewhere. Okay. And she doesn't have a lot of support system. She's maybe with her. I don't remember the exact details. All I remember is that the lady was functioning. She was doing cooking. She was going to the bathroom. She was getting her whatever. She needed to do what she needed to do. She was told that she needed to have the surgery done. With a monocular patient and alone, okay, that functioning well, what was the purpose of me doing the surgery? So she can read and write? I mean, the purpose, so you have to protect. So talking to the patient, understanding their expectations also is very important. Some people, if you're going into cosmetic surgery, some patients have unrealistic expectation. This is important. You need to write this down. Unrealistic expectation. A lot of patients come to me with a retinal detachment, okay? And then the patient expect to see 20/20 after the surgery or 6/6. And it's like, wait, what I'm trying to do is save your eye from being lost. I'm trying to prevent blindness. You may see, 10%, 20%. That's success for a chronic retinal detachment, macula off. Okay. Today, I had a patient who was hit by his, neighbor with this water jet that they wash cars with. This water jet that they wash the car with. You know what I mean? You know what I'm talking about?
That's the
Yeah.
pressure is too high.
And then, pressure is too high and hit him in the eye with that pressure. You can't believe what happened to his retina. It was crazy. And he had a macular hole. His macula, his fovea was torn apart. It was torn. Okay. His macula was destroyed. His optic nerve was damaged. I looked in the eye. I was like, my God. And he's seeing hand motion. He can't see, even count finger. He can't tell you this is 2 or 1. The father expectation, I talk to patients. If it's surgery and I talk to patients all the time. And I'm trying to understand what's going on. And thank God I have a good sixth sense. And I've kind of tried to develop this sixth sense where I kind of understand people in front of me. What they're troublemakers, what they think, good people. This is important to build this thing when you're talking, when you're facing patient. You need to kind of make this little thing grow inside you because that's important. That guy was thinking that his son is going to see, and he wanted the surgery. It's like, Doc, when are you going to do the surgery? Doc, when are you going to do the surgery? I was like, wait a second. First of all, macular holes, post-traumatic macular hole, there's a chance the hole can spontaneously closed by itself without intervention, without surgery. Okay? So your evidence-based medicine tell you should not operate, right? So he's saying he's trying to force his opinion upon you. Unfortunately, I can tell you a lot of physicians get skewed means or get influenced by patients, and they get in trouble. They get into trouble because the surgery gets complicated, and then you ask, why did you do that? Well, the patient said, look, it's not the patient's, he's not a doc. You're the doc. You have the right to say this doesn't work with science. So he kept saying, oh, and then Dr. So-and-so, and that's okay. The doctor, because he saw a macular hole, and so the eye, he probably needed immediate surgery. He's right. He's right in the sense he needs to refer it as soon as possible to a subspecialist. But at the end, it's my decision as a subspecialist to make the right decision for the patient. So anyways, he thought he was going to see. I was like, wait a second. Even if I operate, your son most likely will not gain vision back. Maybe count finger, maybe, but for now I can't. You need to go home, use the medicine, and come back in a week. And maybe what I said to him, just so you know, you are welcome to go and get a second opinion, because I'm confident in what I'm saying. Don't be worried that your patient is going to go and take another second opinion. Actually, I advise patient to get a second opinion, especially, I do complicated things. I do high risk surgeries. So I want my patient to just trust me. He knows that I'm going to do the best for him. If he's a wishy-washy about his decision, then I probably don't want to operate on him, right? If he's wishy-washy, you know what's wishy-washy? That's he doesn't trust you as much. He's, and that's when you get in trouble, those patients, because they have unrealistic expectations. And then also be aware of patients that make you look like God. Oh, you are the only doctor in the world. Oh, Dr. Bahrani, you whatever. So there are patients who are sincere, you know, I mean, and I put that on my Instagram and Snapchat. It's important because you want to feel good about yourself. You want to feel that you're doing good for your patients. But at the same time, be aware of this. Don't get, you know, don't get your feet slipped into this, you know, grandiose thing. Okay, just try to say, because what happens, what I learned, that the time you feel you are above medicine, the time you feel that you are unstoppable, you are invincible, that's when, I don't know, I mean, I think God just tells you, ah ha ha, yeah, you're just a little bitty person trying, you know, and see, you can't do this, you know, you're not God. So I mean, that's why medicine is a humbling profession, is a humbling, and surgery is even more humbling. And the more you learn about medicine, the more you see patients, the more you experience medicine, the more you understand how small you are, you know. So where were we?
Consent.
Consent. So we were talking about informed consent. So risk, you have to tell them about the risk. So if the, you know, success rate of the surgery is 80%, I say 80% success rate, we'll do the surgery. Let's say example of retinal detachment. There's a person, 80% chance we will do the surgery once and we're done. Okay. There's a 20% risk of retinal redetachment. There's a failure, and the failure because the immune system and your cells can form a membrane on top of the retina and causes redetachment, PVR, proliferative vitreoretinopathy, number one reason that a patient get redetachment. Okay. And then there's maybe a 1% risk of blindness. You may need another surgery. One thing unfortunately, sometimes you have to talk about, I don't talk with my patient about money. And that's important. This is my advice. It's a different, you know, it's a different system, right? You were asking me about the system. I can't change the system, but I do what I learned to do is I never talk to patients about money. So if there's a surgery, I say you need to go to the accountant, you need to talk to them about if I need to intervene to give discount or something, I'm happy to do so. But I'm not the face, because the patient shouldn't be seeing you as a dollar sign. Okay, that in my opinion, that's wrong. Okay, you should be away from the money. Okay, but also during the informed consent, you talk about if the surgery failed, we need to do a reoperation. Okay, then you probably need to pay the money for another operation. It's not my fault you stayed hand motion for 3 months and you want your retina to be attached again. Okay, whatever the circumstances, it's not, you know, you can't take care of people at home. You're not responsible for people negligence, for people not following up when they're supposed to follow up, right? So you do have to do and then at the end you have to do the best you can for the patient. And then whatever happens, you have to. So the benefit, so if I do the surgery, what's going to happen? How are you going to benefit from the surgery? So RBA, it's very common in informed consent. RBA, risks, benefit, alternative, other treatment. And you have to talk about the worst things. You can't talk about all complications, but you can talk about the most common ones. And you say, read the informed consent. You're going to sign. There are other things. You can spend time and you can ask me questions if you have. Benefits of the surgery. Okay, yeah, you're going to save your eyesight. You're going to see better. You know, you're going to see 20/20. This is what the goal of the surgery after refractive surgery. And alternative. So sometimes an alternative is not surgery, sometimes an injection, sometimes a drop, sometimes a pill. Just depends what the problem is. So you just shouldn't say to the patient, that's your only option. I have to open up your thoracic cavity and operate. So I mean, you know, that's the only way to do it. Maybe you can do a thoracotomy or whatever. I mean, there are other options. So you have to discuss other options. So these are the three most important things. And by doing informed consent, you're not only protecting your patient, you are protecting yourself as well. It's very important. I can't tell you. You have to protect yourself in the correct way, in a professional manner. You don't cheat the system, you don't cheat the patient, you do it the right way by protecting yourself. And the way to protect yourself and discuss with your patient everything that you know. Everything that you know. So, because honestly, and don't tell me you won't get sued or you won't get complained by a patient against you. It's part of the business. It's part of medicine. I've been told that when I graduated medical school, when I graduated residency, when I graduated fellowship. I've been told by my mentors, I'm going to get sued. That's okay. You just need to do the right thing. And if you get sued, I did the right thing for my patient. And 1, 2, 3, you're fine. As long as you're comfortable with yourself and what you did, then that's fine. You know what I mean? So protecting yourself. It's important because unfortunately people don't think that you have a family, you have kids to feed, you have a mother or father to take care of. You're a human being. You are important to your family, right? Don't belittle yourself. Think about you're important to society, and don't compromise your ethics, and don't allow people to disrespect you. Okay? That's very important. Don't accept disrespect from anybody because you're a physician and you are important and you have to take care of people. And because you are doing the right thing, okay? Because your goal in life, besides taking care of your family, is doing the right thing with your patients. So that's why you have to not only protect your patient, protect yourself, whether you're working in the US, Russia, China, Iraq, anywhere. So that's very important. Because some people can ruin your life, and there's a lot of frivolous lawsuits. People, they're out there to get you, and there are people out there to think that you are rich, and they want to abuse you, and they blackmail you. I mean, so I mean, you have to protect, but do the right thing. Take care of the patient. Tell the patient about everything, and you'll be set for life as long as you put the patient as a number one thing, and you do the right thing, and you're honest. You're fine. I think we're over 2 hours. Well, 2 hours. I don't know. It's an hour and a half. Any questions? I think we're good. Any questions? What would you say are the odds of matching into an ophthalmology program? It's very tough. Unfortunately, it's very tough to match in ophthalmology in the US because unless you're a US medical graduate, it's very difficult. I knew a lot of US FMG, which mean foreign medical graduates who did not match in ophthalmology for 2, 3, 4, 5 years. I mean, they continued, they tried their best. Keep an eye open for all specialties. And then, I think it was tough. It's just they're very small programs, and they have precedence for US medical graduates over foreign medical graduates. If you hadn't chosen ophthalmology, what specialty would you choose? Orthopedics. We talked about how I liked orthopedic surgery, maybe because both are visual fields. I don't know. It's weird. I don't know why ophthalmology, orthopedic. Any questions, Qamar Zaman?
I have one. How can we build our CV as medical students? What are the things, what are the steps that we should take now as medical students to kind of...
Well, be involved in research. I mentioned those things. I tried to say these things. Be involved in research. Volunteer in your time. I know a lot of medical students, I'm sorry to say that, but they have a lot of time on their hands.
I have a question. How can you prove that you volunteered?
Well, I used to get letters from I volunteer at Brackenridge Hospital. I remember in Austin, Texas, I volunteered there. I got a letter. And I volunteered also in a nursing home in Austin, Texas, when I was a pharmacy school student. I got a letter from the nursing home. If you volunteer, let's say with me, you get a letter at the end of the volunteering. You have to get an official letter, otherwise people don't believe you. Be involved in organizations like leadership organizations. I was involved in many leadership programs. What is it called? Hero, helping everyone reaching opportunities in education. I remember it's in my CV, still there. I was in part of a VP, a vice president of the organization. I was a student, orthopedic surgery president club. I was involved. I had to. Otherwise, I won't be accepted in whatever I need to do. So you need to kind of, what else? Yeah, shadow doctors, shadow doctors, shadow surgeons, go to the clinic. I'm sure people will be okay, like a friend of the family doctor. Hey, I want to see what you do. Can I come to the operation room? You know what I mean? You
But will
all
that
have
be valuable?
family doctors in your family.
But will that be valuable on your CV? Because that's not experience for you. You're just looking at people doing
It's
their thing.
very valuable. It's very valuable. I mean, for me, because you want to experience, you want to know what you're getting into, right? I mean, if you come to me and I'm a program director of an ophthalmology program in the US, say, tell me, what do you know about ophthalmology? I'll look at you this way and be like, I forgot everything. So if you tell me what, I was like, oh, I just heard it's a great, I love to do laser surgery. I think it's pretty cool. Come on, give me a break. Did you go to an ophthalmology clinic? Maybe you can't get binocular vision. I mean, I can't see in the slit lamp. It's kind of geeks. Ophthalmology is for geeks. It's like you're looking into this microscope. It's like you're going into the lab and you're looking at the mitochondria and this. Seriously, I mean, it's kind of crazy. So no, seriously, you have to know what you're getting into, honestly. So if you go into orthopedic surgery, man, do you know what they made me do during when I was a student? I was holding a leg up like this, and then I was at the end of that foot, and I was holding the foot like this for 3-4 hours, and then they were repairing that leg or whatever. I mean, oh my God. Seriously, I did that.
Medical students are a very important part of the team, I see.
Well, did you see that? I'm so sorry. This feels so bad putting it that way, but the picture of the attending, then the scrub tech, then the fellow, and then the trash can. So don't
and then the medical
student
yeah,
comes after the trash can.
Yeah.
Dude, I was in the operating room for hours, and I'm holding that foot and what are you doing? You know, stay there, like tight, pull. You know, orthopedic surgeons used to piss on in their pants, on their scrub when they operate for, you know, 10 hours, 12 hours. I mean, seriously, that was serious business.
I heard some wore diapers during the
Yeah,
operation.
yeah, absolutely. I mean, so you have to know what you're getting into, seriously. Because if you do it, I mean, honestly, let's say I had moments in medical school where I didn't want to continue. I didn't want to finish. And you do get that. And consider your choices. Yeah, I mean, you're a human being. I mean, be honest. You probably never say that to your friends or family because, oh my God, all our hopes are based on you, Dr. Qamar, and you're telling us that you're not going to be a doctor. Oh my God, shame on
Wallahi,
you.
my parents forced me into medicine. But I like it. I like it enough to continue.
Yeah. So my dad was the wonderful thing about my dad. He never got me into, you know, like you need to be a doctor and all that stuff. He's like, this is a major decision. You have to do it. And that was the thing is I can't go back and say, Dad, it was all your fault.
Yeah.
It's like, it was my decision. Yeah, it was my decision. So what else we should, any questions?
Here we have limited resources as medical students. So what are the ways we can improve ourselves?
I think you do have a lot of resources.
In the university, I mean.
Well, that's what I'm saying.
We barely have cadavers. What resources do we have?
Barak, we have 8 cadavers.
We have had
8
the same
cadavers
for like 15
Let me
years.
tell you something. The other week, like 2 weeks ago, we had an examination. It was a quiz. The cadaver was literally, it was a female cadaver, and her mouth was wide open, staring at my soul, and I was trying to do the quiz. And the formalin, what is it? The formalin aldehyde?
Formaldehyde.
The formaldehyde got in my eyes, and I started crying. The doctor was counting to 10. Let me share the story. The doctor was counting to 10. واحد, yak, do, se. And we all thought he was kidding. We're like, oh, yeah, it's so funny, doctor, you can stop now. And then he got all serious, and the cadaver was right in front of me. The formaldehyde is in my eye. I started crying. The doctor comes to me. He's like, "I'm so sorry. I didn't mean to make you cry." I'm like, "No, it's not you. It's the cadaver." He's like, I know, it's me. It's fine. You're a girl. It's fine. I'm like, okay. Can I get extra 5 seconds? He's like, sure. I'm like, great.
Oh my goodness.
So so we do have cadavers. We do.
So how many cadavers do you guys have?
I didn't say we didn't have cadavers. I said we have the same cadavers for years on years on years on years.
Yeah, I heard that. I heard that.
They're really dissected.
Yeah.
They dissected the bone.
Well
so bad.
Well dissected.
I agree.
So bad. Like,
so what you should do, Barak, what you should do, you have to make the best out of what you have.
We do
Okay?
make the best out of
That's
what we
true.
have.
So if I was in University of Texas Medical School in Galveston, there were other medical schools in the US which were better schools than my school. My school wasn't ranked the #1, medical school in the country, correct? Okay, but I was able to get to Harvard Medical School and doing my vitreoretinal surgery fellowship at Harvard. So I got there. So don't say you have resources. Try to make the best out of what you have.
Yeah, I know that.
One of the famous doctors who graduated from medical schools in Iraq, whether in Erbil, Basra, Baghdad, Mosul, they're one of the leaders in their fields all over the world.
Except it's really sad because I know a lot of people, a lot of doctors who went abroad instead of flourishing here as medical doctors, as medical practitioners. They went abroad because a lot of the doctors don't get the opportunity to express
to shine,
Exactly.
to shine,
Express their
because the
experience.
system prevents you from shining.
I mean, I have friends on
Well, I mean,
Twitter.
don't, honestly, is it the system prevents you from shining? And
Exactly.
in the US, in the developed country,
You're
when
supported.
you shine, they put the spotlight on you.
Here you're fought.
They put the spotlight on you, right? Because we have a famous doc here. Look what he's been doing this. So it's kind of, they reward you for doing something important or something like that. So one of the things I wanted to say also, focus on yourself. When you focus on yourself, don't worry about other people. Focus on how you do the best surgery you can do in the safe manner, in a good manner, make the patient happy. Then don't worry about other people. Don't worry about what people say. Just focus on yourself. Don't get into talk about other colleagues. Never do that. Your colleagues are your friends for life. They're your colleagues. Don't trash anybody. Don't trash doctors. Don't talk about anybody. That's very important. And just know that patients who talk about doctors in front of you, they're going to talk about you when they leave. So be professional. Always keep that professionalism going. It's important. It's a very important part of our teaching when we were in medical school to learn what professional is. Okay? So you respect your colleagues and don't worry about competition. Don't worry if the other doctor is doing 20 surgeries and you're doing 10 surgeries. Maybe you're doing one complex surgery that equals to all the 20 other surgeries. And maybe you're doing it at a higher quality than somebody else. So be confident, believe in yourself, and don't worry about other people. Worry about yourself. Improve yourself. Go to conferences, learn things, learn things from your friends and from your, maybe even your competitors. Ask them. Open a conversation with them. Say, hey, how did you do this? Did you have this problem? It's honestly, we all, and by the way, if you have that question, most likely other people have that question as well. Okay, what else? Who can do this? You guys study a lot, right? So tell me, what else? Any questions?
What's your favorite thing about being a doctor? And be honest.
Oh, true.
About being a
That's true.
doctor?
Yes.
Now?
Yeah.
And
Yeah, we
don't
know-
say
no,
don't
yeah,
say
we know
don't
the
say don't say
patient,
change
you know,
lives. Don't say we
change
save
lives.
lives. Don't say we give people back their vision. Something realistic.
Well, I mean, if I think too much about it, it's not going to be sincere. I mean, I truly, that I'm doing something great.
Yeah, it's like having a
But-
purpose. Yeah.
That, yeah, I mean, that purpose that I feel I'm doing, I'm the best and I'm the badass and I'm, you know, I do the best for my patients and I do the craziest things and I have a great outcome and, you know, you know, and that's great. And I get respect from people. And a lot of things, but after a while, this kind of, that's early on maybe, but after a while, you want people to recognize what you're doing as something is good. Okay, that's important. People, you know, what we call in Arabic taqdir, and that's wonderful. And that's what wonderful working in Kurdistan is. People taqdir, they have taqdir for what you do, honestly. Yes, I do have competition. I have people, you know, say things that and all that negative things vibe. But at the end, people do respect what you do. People do recognize things, and you get that more here than you get it in the US or in the UK or whatever, you know? So that is important, you know? So, and then, you know, when a lady see you for the first time and say, "You're my doc," that's amazing. That's, I know you're saying save lives, but it's amazing when the patient can't see anything and they go in the operation room, and maybe after a month they look at you like, "You're, you know, you look young. I thought you're older," whatever. You know, that's crazy. She didn't see, that lady did not see anything, and that, you know, or that man, and then people do, you know, they make dua for you. I mean, that's all important. You know, I know it's sentimental. We say sentimental, but it makes a lot of difference. Kind word from patient really makes a huge difference. When in the US, you get cards from patients and thank you for what you have done in this. Over here,
Here you
patients
get
say,
Doma.
huh?
Here you get Doma.
Which is great,
Yeah.
which is amazing. So these are things people, you know, don't, you know. And then one thing that I mean, it's a blessing when you can do something, or God put you at a position where you can help other people. Because, you know, some patients, you know, they want to help. They want to help, but they can't. Really, I mean, they can't. But you are in a position where you can help other people. I think that's great as well. Yep. Anything? What about you, Sumaya? What about you, Awa?
I had one question.
Yes, Awa.
How well you do in med school, does that really like shape what kind of doctor you're gonna be? Like, I'm sure not all of us here study every day. I know I don't. And sometimes I
Same.
feel really guilty and I'm like, am I gonna be like a bad doctor in the future? And I don't know, I'm still a second year, so I have a long way to go.
Yeah.
Still, sometimes it just hits me and I'm like, I should work harder. And so I just want to know if how well you do in med school actually shapes how you are, what kind of doctor you're going to be in the future.
Well, I mean, I think it does influence, and I think it does influence. It influence how, because the grades you make in medical school matters when you apply to residency. I'm talking about the U.S. system. I don't know how it works here. I don't know how you get into ophthalmology in Kurdistan or in Iraq. I don't know, but it does. I mean, I worked my butt off, you know, to get good grades, to, you know, do everything I need to do. And I took the USMLE, which is a very important step in medical school in the US. USMLE step 1, step 2, 3, you know. Step 2 was step 1, golly, step 1. It was the
Step one is the
toughest, one of the
preclinical,
toughest.
and step
People
two is the
take a year
clinical.
to
Step one.
prepare for that.
And I got, I think, a 99 percentile on it. And that what paved the way for me to get into ophthalmology. That was a big criteria, you know, as a residency programs, ophthalmology residency program, they have criteria. That's one of the criteria. It's not everything. Yeah, you may get a 95th percentile, okay? But you're a great person. You are wonderful to talk to. You have other extracurricular activities, like Barak said. Why it's important? Because in the US, they want a full package. Yes, you may
Holistic
tweak it,
approach, right?
this, but then you can make it up in a different way. You know what I mean? I think in Kurdistan it's different. I don't know if it's true.
Yeah, they
I
mainly
think
care about
it
grades here.
mainly grades.
Yeah.
So
Um,
even getting into medical school in the US, you not only have to get good grades, but you need other things to help you.
like a
One of
certain
the things,
attitude.
there's the Mcat exam before getting into medical
Yeah.
school in the US. And I did poorly on my English, comprehension section. It's crazy. They have these like huge, paragraphs, and you have to they ask you second, third level questions. And English was not my first language, not my mother language. And I had really tough time. I did well in biology section, physics section, I did well, but the English language was just tough, really tough. So what I did other things to prove, so I had volunteering, this and that, to make a good CV for myself. So, and that helps in the US. Here, I don't know how that works. I don't think it matters.
It doesn't matter. It's
Unfortunately.
only grades.
Yeah, unfortunately. So yeah, it does shape, Arwa, it does shape. What you learn in basic science does help you when you get out. And it does help you. As I said, I consider myself as a good doctor. And one of the reasons I say that is because I have my basics nailed.
I have a question about the US Assembly. When you
Yes.
did it, was it still a 7-hour exam with 20,
Yes.
180 questions and all that?
Yes.
And how was it scored? Was it still like out of 300 basically, or was it out of 100, I think?
I think it was a 99 percentile score and a number score.
Yeah, it was a 2-number score, right? No.
Yeah, there's a 2-number score. I think, I really don't recall this. I think I got a 39 or something like that, which is a 99 percentile. Like in you get to orthopedic, you need to get 44, 43 or something like that. I don't remember. I could have gotten into orthopedics. I could
sure
have.
you would have. I'm sure you would have.
Because not because my USMLE step 1 wasn't the greatest. It was great, 99 percentile. So it wasn't gonna hurt me. It's okay. That's good score, But other things could have helped me, like being the president of the Orthopedic Surgery Society, publishing in arthroscopy, working with guru orthopedic surgeons, establishing rapport with other doctors, like from Baylor, other places. Maybe I get a good word, word in. Somebody will say a good thing about me, So that's how it works.
Another question about the paper you said that you did with the fellow about the
Yeah.
muscle thingy. Where is it published? I'm gonna look it up.
Arthroscopy.
Okay, thank you.
You
What's
can,
the name?
I have 6 or 7 publication. You can Bahrani HM at pubmed.com, at pubmed.gov.
Yeah.
You put Bahrani, which is my last name, Bahrani, H, just space H or space HM, and you'll see it there.
Yeah, thank you.
I published on monkeys in IVOS, one of the most famous publication in all ophthalmology. And I publish in Retina, one of the most famous journals in retina world. I mean, so those major journals are crazy. I mean, this is like a crazy journal. You're talking like being published in the best journals in the world. So that's it's different. Like if you're getting interviewed by a research person, a PhD, MD, PhD, and he'd be looking at this, damn, he published in Retina, he published in IVOS. So these things matter for doctors there.
Did you do them before you got into residency, or was that after?
No, before.
So these helped you in residency applications, right?
Yeah. No, it helped me get into residency.
Okay.
Yeah, it helped me get into residency. That was major important thing for me, because ophthalmology was tough. I was the only medical student out of 200 people to get into ophthalmology. So think of that.
It is still very, very tough now. I mean, they have their own match, I think.
Yeah,
Yeah.
Separate match.
dermatology
They have a
and
new a
ophthalmology.
different match.
Yeah, they have a
Ophthalmology
separate match.
Yes.
Urology and ophthalmology are separate now.
You're right. So I mean, don't not just because I'm an ophthalmologist. There are a lot of other beautiful things in medicine you can do. Ophthalmology, nahsan. It's like, and retina is even more. So think about that. I mean, maybe this is not what is for you, right? So maybe you don't like to be dealing with patients. Maybe you want to be a radiologist. So you have to think about those things. You have to kind of think about those things is important. It's a life. How do you guys get in? Do you just get good grades and
Yeah,
then-
mainly here is grades. There's a grade system, and there's a cutoff for grades.
so Arwa, it makes a huge difference
Apparently, yeah.
because you have nothing else to pick you up if you don't do well. Like if you're a medical student, a US medical student, if you don't do well in let's say USMLE, something else can pick you up.
I think it depends
But
on what
here-
country she wants to go to.
What?
I think it depends on what country she wants to practice in the
I
future.
was gonna say that maybe like if you're planning, like for example, if I'm planning to travel abroad and do PLAB or USMLE, that I think kind of does it differ? It differs, right?
Yeah, I think it's different, but I think they will look at your grades also in your medical school. I think they will look at that. That's important. I mean, I was part of, I interviewed a medical student for our residency program. I also was on the fellowship committee when we interviewed fellowship for our fellowship program because I worked at the National Retina Institute and we had retina fellows. So I kind of have an idea. Do you know what was the most important criteria we looked at? This is a secret. It's a pearl that we looked at when we chose our fellows. And I learned that from my my mentor in the practice.
What drink do you like the
Bert
most?
Glazer. So one of the most important thing to kind of gauge the future success of that candidate or that fellow in our program, guess what? Give me some like few guesses. What character of that person?
How they interact with the other fellows or the other residents.
Okay, that's
they'll be
an answer.
Fit or not.
Next, another answer.
Confidence.
Okay, next.
Eye contact.
Okay, next. Anything on your mind?
His humor.
Okay. We were trying to judge this thing. We were asking questions to know
What is their
if this
favorite
person
meal?
is going to be successful, if he's going to be a great
Body
retina
language?
fellow. Huh?
Body language?
Okay. So most of you talking about
Doctor,
communication.
what about asking where they would see themselves in like 5 to 10 years? Because
That's a good question we ask everybody.
Yeah, it's very common.
Maybe asking them what success is to them.
No, let's say attribute, personality. Personality. What kind of personality?
Hobbies and talents. Other hobbies.
So it's
Or
curiosity.
surgeons, artistic, I think.
Curiosity.
Oh,
So that person needs to be so curious. He wants to know what the hell is going on, why this happened, what is happening, why did this thing happen? I mean, this guy wants to know. He doesn't let it go. I don't let things go. I'm pretty curious. I'm pretty curious monkey, like what's the monkey? George monkey? What? It's a curious monkey. I like to kind of find out what is going on. And it just bothers me not knowing why this is happening this way. What is the disease? You know, sometimes we can diagnose things, and we have a lot of uveitis patients. Sometimes we can't understand why they're having this problem, and then so curiosity, that's one of the things we pick fellows. If we kind of sense that he has a sense of curiosity, that he wants to know, he will not stop until he gets down to what is happening. And those people who have those personalities do well. And that's not from me. That's from my mentor at that time, Bert Blazer at National Retina Institute. He's a famous vitreoretinal surgeon, one of the pioneers also. So that's a pearl. Stay curious. If you want to know, if you're reading something, just pass by it. Just know why this happened, you know, why this patient is walking that way. Do you know, I mean, if you've seen those medical, like Grey's Anatomy and this, and, you know, why this, there's this show about this doctor who finds these crazy diseases. He's a curious guy. He sees this guy living next to a pigeon. Pigeons live next to him. And he has this very weird pneumonia. Oh, this is Cryptococcus pneumonia. Okay, because of the pigeons living
I'm pretty
next
sure
to his
that's House.
and, you know, whatever. He has lots
That
of
is
rats.
an episode of House.
Yeah, that's
Right?
House.
House. Yeah,
Yeah.
House. Right?
Yes.
So he's a curious guy. House is a curious guy, and that's why he's such a great physician, because he's curious. So always stay curious.
But not as curious as House, because he was kind of
Don't
say
spoil.
unhinged.
Don't spoil.
Well, I mean, we're always, you will come maybe and see me do something. I'm not an angel. I'm not an angel.
No, House was
But-
just weird.
No,
House was
that's
just
why.
House-
weird.
Yeah,
House
he's
of
weird.
Narcissus.
Right. So I'm weird also. I have my own weird things. I mean,
No, that's House. Not like
So-
House.
yeah, I
Trust me,
mean,
not
you know.
like House.
Anyways, so everybody has their own things, you know.
They're
So
quirks,
you
yeah.
take the good things from everybody and add it to your system, and leave the bad things out. So take the good things from that person, leave the bad things out. So you take the good things from this mentor, and you will shape your own way, and you'll be Dr. Ali Mahmoud, Ali Nizar. You have your own, you shape your own personality, your own way, you know.
I have one question. Last year, one of the doctors at uni said something. He said that sometimes it's necessary to lie to patients to save their lives. Is that moral or necessary to do sometimes? Like, for example, if there's an emergency and the patient is adamant not to do the surgery, but he needs the surgery now, or else he's gonna probably lose his life or something very vital. So would we just say, oh no, you're gonna die like right now if you don't do it?
That's a
And
good
then-
question to put it in an interview setting, you know, because we ask about in the interviews, we ask about ethical questions and stuff. I don't think lying is never a good thing, and lying in medicine is a huge big no-no. Okay, if the patient wants to die and they don't want to they want to go blind.
Maybe because they're not well informed or ignorant about they're ignorant about the procedure or the risks or the benefits of that procedure.
If
so-
the patient is he has lost conscience, or he's not, you know, he's not
in a
within
correct
it,
state of mind.
you have to do you have to do emergency intervention to save his life. But it's lying is no, of course you can't lie to. But I don't deal with life and death situation. I
Yeah.
do sometimes, but I can talk about. I'm only the eye doctor. Don't ask me about anything. So I can say that some patients have chosen to go blind over doing surgery. It happens. It happens a lot in my field, in my,
True.
She says, the patient says, I'm not going to do surgery. I'll go blind. I don't care.
Mhm.
Yes, yes, people who make that decisions.
Wow.
You can't force people. Don't. And there's one thing. Oh, it's important. Let's talk about this. There's 52 people, 4 people left. I'm watching you. Don't convince patient. It's not your job to convince patients to do something.
Because I've seen it in a lot of medical TV shows, like Grey's Anatomy, The Good Doctor.
Yeah, it's called like أقنع المريض يسوي عملية.
Hey, طريقتي.
It's not your job. قنع. And there are some places they have a patient specifically there, so they convince the patient to do the surgery.
Yeah.
It is not your job to convince the patient to do the surgery. Your job is to give the patient all the information necessary to make a educational, informed decision. Informed decision, meaning you tell them about the risk, benefit, alternative of the treatment, and they make the right choice for themselves.
True. Like we need to rid ourselves from this white doctor savior complex. Yeah, and you're here to save lives, but you don't.
Well, you
can't
as a
intervene.
student, this is what you're doing in medical school. You want to save lives. You want to do that. That's fine. No, keep up that feeling that you have. I'm not trying to say don't do it, but there are rules in medicine that you have to follow, and don't cross those things. Okay, so you are not there to convince the patient you need to do this cataract surgery or you will go. You say if you don't do the surgery, there's a high risk you will go blind. And that's your job. And patient disagrees, write down in the notes, patient declined surgery because he thinks he will die, period, right? There's people who think they're going to do surgery and they're going to die and they die, right? Haven't you heard of these things? I mean, people have a sense that they may die and they come. So, you know what I mean?
Yeah. Things happen.
And sometimes I feel patients come because they want to go blind
or die
here with me. Like, don't get blind over here, So, I mean, just give your patient information so they make the right decision. And one thing about our system here that you have to do, the patient is not alone. The decision is made by a whole family. Okay, few of the times the patient makes their decision alone.
Sometimes the patient is not even make the decision. It's the family that does that.
You have to talk to the patient's. Let's say a mother comes or a lady comes. You have to, and she comes with her daughter. Okay, don't send the patient to the operation room and then sign up the paper and go into the operation room without talking to the male people in the family, her son, her husband, whoever is in the family. You need to be considerate of the cultural differences. This is very important, okay? And that's what I've learned over the years. You have to keep this in mind.
Yeah, autonomy is centrally appreciated here too.
It's important. It's very important. So you have to talk to the male household leader, whatever household
patriarch.
Person, the person responsible for the family. And maybe it's the son, it's not the father. He's involved in everything. And be aware of, talk to and sometimes you have to talk to this is a joke, to the neighbor. Because you know, where did you go? Well, I went to Dr. Bahrani and he said you need a retinal detachment surgery. Oh, well, you know, my husband got an injection and he got treated, retinal detachment. Hey, it was a different retinal detachment. There's like some edema and the retina is detached. Maybe the term in Arabic or Kurdish is the same. So there's kind of miscommunication.
Mhm.
It's like, I got an injection. While you're doing surgery, you're going to go blind and this and this. And people interfere. They sit in majlis and they talk and they get ideas, they get opinions from other people. People are influenced. So it makes a big problem for you. So what I do with my patient, I say, who is the main responsible person for mom? I need to speak to them. So she says, well, I'm the daughter, you can speak to me. But my brother who is, taking care of the family, on he can't come because of his job. I was like, fine. I want him to be here on the day of the surgery so I can speak to him. And I write in my note, I will not operate until I speak to him. So I do that. And it made my life so much easier. And I learned so much by talking to patients before surgery, made me learn about my patient. I avoided miscommunication. I avoided problems. It changed so many things for me. And then when I started talking to patient in detail, and this before the surgery, I mean, this is routine. This is what I used to do, but I start doing it with the other family members, not just the patient and his son or his daughter or the youngest son. And then after the surgery where the problem happens, you get the eldest son come. It's like, what happened? What's going on? Well, where were you? Who are you? It's like, well, I am so and so. I'm the son. I'm the eldest son. It's like, well, you weren't here before. I spoke about all these things and you weren't here. So, and then, seriously, I mean, you have to, this is a cultural issue you need to tackle. You need to understand this is very important. And I'm sure you experienced this in your family. My dad got sick and he was having some left hip problem. And it was a major thing. He needed left hip replacement. So, and then I witnessed the dynamics of the family making a decision about my dad having to do surgery. And I was like, oh my God, seriously, I never knew there was so much going on and dynamics happening between the brother, the sister, the mother, the father, and then getting to a decision. And then I start feeling more empathetic toward my patients. Like I felt feeling sorry for them. I was like, yeah, it's truly a difficult thing to make a decision about surgery when you have so many opinions, so many people telling you left and right and, things. So I was like, my God, now I understand this guy didn't do the surgery because of 1, 2, 3. Our society is very, very complicated. Our cultural system is very complex. It's not like in the US. The US, somebody will come, you will sign consent to the surgery, and you're done. Go. You're legally protected. And you have a witness to witness that thing, and it's done. Period. It's that simple. Here, you have to take care of the cultural issues surrounding the patient. So it's not just the patient. There are so many other people. And if you're dealing with Ashira, I swear, I brought head of families. I brought head of Ashiras into my room and I talked about the risks, benefit, and alternative of the surgery. I swear. I mean, those kind of surgeries where I'm the only person that can do the surgery, it's a high risk surgery. There's high risk for blindness, high risk for this, and this. For example, I operated on a lady about a month ago who was pregnant and had a retinal detachment, macula on retinal detachment. So it was emergency surgery because the macula was still on the retina. So the retina, the macula is still on. That's the set where you see the best vision, the visual acuity, where you see, where you read, you write in that little, you know, that macula. It gives you the 20/20 vision. So what did I do? I asked her husband to come, her brother to come before I did that surgery. I told them there's a risk we may lose the baby because she needed to do to undergo general anesthesia because she couldn't handle local anesthesia. She said, I'm not going to do that. So we talked about risks of losing the baby. It was like a first term, like a 4-week pregnancy. So it was still early on. And we talked about the risk of the baby, you know, having some defects, birth defects, because of the medicine we use, because of something that we used, you know. Any other things?
How about if the opposite happens? Like somebody comes, they're determined, they have a problem and they need a surgery. Or they are convinced there's something in their eye. It's psychological. What do you do? Do you give them a placebo? Do you try to convince them there's nothing wrong? If they want,
You don't, you see, you said convince. Don't convince anybody.
I think that's a medical
You
issue.
say,
Actually.
you say,
psychological
I'm
issue.
Dr. Bahrani. My opinion is 1, 2, 3.
So you just
And then if my battery is getting low, and you say, I advise you to get a second opinion to make sure you want to write a report for them or do something.
if they're still not convinced, do you do anything or do you just
You're not convincing them. If they don't believe you,
well, yeah.
if they don't believe you, it's not your job. You're just got to give your opinion. We good? So I think we call it a day. If we can do this in the future, but let's kind of, you know, if you want that. How did you like this? Do you like this?
I
We
found
do,
it very
but-
beneficial.
It was
It was
amazing.
great. It was great.
Thank you so much, doctor. It was
Next
amazing.
time we can actually go Facebook Live.
You can what?
We can actually go Facebook Live. This is like the thing is, this happened before. Like we've gone Facebook. We've like what is it? Live streamed. We've live streamed the sessions before, and it worked really well. So we would have the session here on Zoom, and it would be live streamed on Facebook as well.
It's fine. I mean,
But I don't
people
know
are
what happened.
angry at me because I went on Instagram, Snapchat. It's all because
One
you.
day we
Yeah,
got the idea from.
yeah.
So we
saw.
can post it. We can post it on.
Totally.
I need it saved, so I can please put it on my YouTube channel.
We will definitely.
So
The
don't
hosts-
forget to subscribe, like, and share my YouTube channel. I'm working on my YouTube channel, so please. Did you know I'm doing
Spread the
live? I'm
word.
doing live comment
Yes.
narration on my surgery. So I put the mic, and as I'm doing the surgery, I'm talking to you, and
Yeah.
I'm teaching you. And
I hope you have the consent of the patients to do that.
He does. He just talked about informed consent.
I'm just joking.
Yes.
I thought the joke was obvious.
no, I like that
It
you're
was
thinking this way.
dry. It was dry.
I tried. Let me be.
Good. You're becoming a Bahrani. That's good. You have to have that kind of a mentality. You have to kind of think about these things. Trust me, that's what makes you different from people. And if you, for whatever reason, end up, you know, and one more thing, last thing. Document. Write everything. Man, people here, like, or some other places, I see that they don't write a lot of notes, like their physical finding. It's important to write your physical finding. If you communicate with a patient and let's say patient declined surgery, write this as a note for yourself. Patient declined surgery due to social reasons, period. Her husband didn't agree with the surgery, period. Do you know, when I've opened the files and I go back 2-3 years, man, these things help me so much. It helps a lot.
You can find a pattern too.
Yeah, just document things is very important.
Yeah.
Like write down everything. All right, so good night to everybody. Good luck to you.
Before we leave, someone just asked me, they want a picture. So
Oh,
let's pose.
all right, let me look good.
And if anyone wants to open their
Come on,
cameras for the
make your hair.
picture, يلا عاد روحكم.
عدلوا روحكم.
علي يفتح الجلوب.
Ali يفتح الجلوب.
علي
and then everybody.
علي
Come on, we want to see all the like shy people. Rawash is out.
It's a memory, guys.
dungeon.
Guys, it's a memory. It's a ذكرى يعني. It's gonna be something fun to look back in 10
Diari,
years.
Baran, Sarah, they're all beautiful
calling me?
people.
My bad.
What happened? Bye-bye. Okay.
And then IFMSA Kurdistan Binyat is gonna take the picture.
Stop laughing.
Okay, done.
Okay, great.
How did it turn out?
Wait, but he should
I-
tell us when he's taking the picture.
It's
No, it's too late now. Yalla,
No,
good
I
night.
mean like we should pose.
Pose, yeah.
No
Oh,
retakes.
Binyat.
pose.
Binyat,
No retakes.
unmute yourself. Unmute yourself.
Anything else?
You want me to take it again?
Yeah, again, I think people
Yeah,
blinked.
tell us when you're taking the picture.
Yeah, واحد
Alright.
اثنين ثلاثة.
Exactly.
Okay, 3, 2, 1. Done.
Thank you guys for joining the session and sorry for the technical problems.
Thank
This
you
was-
for organizing the session. It was a great
Yeah.
session.
Thank you.
Took some
We
time,
were
took some
so
time.
happy to
My
have Dr.
YouTube
Hasan
channel.
Bahrani.
Don't forget about
For
my
sure,
YouTube
guys.
Don't
Subscribe,
forget
guys.
to like and subscribe and share the video with your
Yes.
friends and family members and your
Yes,
neighbors
yes,
and your
let's do
neighbors.
it.
You're such a YouTube girl from now on.
I'm
it's
such a
just-
YouTube.
No.
Ah.
Tama sounds so natural when she's saying that. I think you need to hire her
لا
For the
إيه.
outros. For
You're
the intros,
publicist.
for the
You're
intros.
publicist.
for the intros.
Yes. Take care, guys.
You too, doctor. Thank you so
Good
much.
luck.
Thank you,
You guys will
Thank
be
you,
great.
doctor.
If you have another
Thank you,
subject you
guys.
want to talk about, just put it up and then we'll discuss it in the future. Or if you
Great.
have questions or some issues and you want my opinion about it, we can make another session.
Inshallah.
Okay,
Great,
doctor.
great. That
Thank
would be
you.
great.
Take care,
Thank
guys.
you. Thank you
Have
so
a good
much.
one.
You too, doctor.
Thank you, guys.
Good night.
Night,
Thank
everyone.
you,
Bye
doctor.
bye.
Thank you, everyone.
Thank you.
Bye-bye.
Bye bye.
Bye.